Good evening, friends, and welcome back to the Thursday evening PG teaching session brought to you from LTMMC Sion Hospital, Mumbai. As you know, in the monsoons we had gone online and now we are back to physical classes. So those students who are in Mumbai, we are requesting them to try and come here physically so that there's better interaction and better learning. And the rest, of course, can continue to view these classes online. We thank Aristo Pharmaceuticals for an educational grant which helps the live relay and webcast of these sessions. They can be watched on www.clinicalpediatrics.co.in and on the DIAP platform live. And you can put in your questions there and you can answer questions which we are asking here. So please participate and it will lead to better learning. Today we have two cases for discussion. The first case is being presented by Dr. Rok Singh Pawra. So I invite him to start presenting the first case.
Good evening everyone. Myself Dr. Rok Singh Pawra. I am going to presenting today's evening Thursday clinic. 1 year and 6 month old female child, first by birth order, born of non-conscious marriage, resident and hailing from Raigarh, Hindu by religion, tribal community, brought by father and informed by father with chief complaints of swelling of bilateral lower limb since 3 days and fever since 1 day. History of presenting illness. Child was apparently normal 3 days back when father noticed swelling of lower limbs which was gradually in onset involving both the lower limbs and progress from feet up to thigh over 2 days and has remained constant, not associated with any diurnal variation. Then after 2 days, father noticed that swelling progressing to the face in the form of swelling around the eye, which was more around the morning hours of the day, but subsided over the day. Then also developed abdominal distension after 1 day, which was gradually progressive, painless, not associated with vomiting or loose stool, not relief on passing platters. Since 1 day, child also developed fever which was mild to moderate, undocumented, not associated with rash, intermittent, subsided. Child was lethargic in interfebrile period. In view of above complaint, child took local medication which afforded no relief. There is no history of decreased urine output, increased frequency of urine or dysuria. There is no history of breathlessness or feeding difficulties. No history of suck rest cycle, forehead sweating or repeated LRTI. No history of jaundice or any bleeding manifestation. No history of poor weight gain or skin changes. Or there is no history of similar illness in past or no history of Cox and Cox contact. On further inquiry, father gives history of mild cough called 10 days back. Past history. There is no history of similar episode in the past, no history of previous hospitalization, antenatal history. Mother is booked and immunized, not taken iron and folic acid supplement, no history of hero with rash and oligohydramnios or other antenatal complications. Natal history, full-term normal vaginal delivery, birth weight was 3.5 kg, baby cried immediately after birth. Postnatal history, there is no history of NICU admission, no history of perinatal hypoxia, no history of neonatal seizure or neonatal hyperbilirubinemia. Immunization history-wise, immunized till 9 months of age. Developmental history-wise, gross motor wise child can runs and fine motor wise child can scribbles and socially waves bye and language wise bisyllable. Impression appropriate for age. Dietary wise expected calorie 1000 kilocalorie and observed calories 441.5. So deficit is 559 kilocalorie and protein expected protein is 12 gram and observed protein is 106 and deficient is 1.4 gram. Family history and socio-economic history. Mother age is 20 years and father is 27 years. Family belongs to lower socio-economic class according to modified Kupusamy scale. There is no family history of other renal disease or similar illness. Sorry.
Okay, so 1.5-year-old child with 3 days of bilateral edema feet. So what is your first thought process? What is your first thought process? Nephrotic. So nephrotic, you usually tell us that it starts from the face, no? Puffiness of eyes and all. So can it start from the feet? Or what is the logic of that starting? What does it tell us? So 1.5-year-old boy with edema feet noticed since last 3 days. Then we'll progress further. Started with edema feet, noticed last 3 days.
So where the edema is first noticed can give a slight hint about the origin of the edema. So like if it is a renal cause of edema, we would expect it to be facial with periorbital puffiness more in the morning on awakening. And if you're looking at like pedal edema, usually it could be seen more with cardiovascular causes.
Correct. So that's what you usually see. So now in this child, will you say that nephrotic is ruled out and
No.
this is cardiac?
No, we cannot say that.
Why not? You said no, pedal edema is gravity and cardiac and all that. So then in this child, nephrotic should be ruled out. This should be cardiac. So how will you clarify that further? What more do you want to ask in the history?
During the day, when it is maximum, in the morning or in the evening?
So he said it doesn't vary. It is same for last 3 days. So does that mean something else totally? Which edema doesn't vary? Which edema feet or edema legs doesn't vary with the day and time? Lymphedema. And? And? Even deep vein thrombosis wouldn't vary. It would be same. So now are we thinking of all those here because it didn't vary? So what more questions? What is the first thing which I think the history didn't tell us, which is very important?
Nature of edema, fitting or non-fitting.
On history you wouldn't know that. That would be on examination. Okay? You're right that would help you separate lymphedema from others, but it will be on examination. Just now we are on history. So what is the usual one sentence which we always talk of when we talk of nephrotic? This child was
Absolutely all right till now.
absolutely all right. So was he absolutely all right before this?
There is a history of cough cold 10 days back.
Cough cold is a
Is
minor
mild
illness,
ones.
but otherwise active, playful, eating well, everything normal.
Yes, sir. Yes, sir.
Everything normal.
Yes, sir.
So now coming back to the discussion, when you first said lower edema legs is cardiac. So can this be cardiac now? Tell me. Unlikely. You are sure it's not cardiac. Means I am asking you how surely can you rule out nephrotic versus how surely can you rule out cardiac?
So cardiac we can rule out surely.
Very good. Why?
Because like edema is a direct sign of failure and there is no preceding history at all, and directly a child at 1 year 6 months is landing up into failure is very unlikely.
No, it's not about the cause, it's about the symptomatology. So, which cardiac failure in children comes with edema feet first as the sole manifestation? It is usually the cardiac manifestations which will come first,
Yes.
and then when it is little long drawn out, you will get edema, right? So, you can definitely rule out cardiac, but it can be malnutrition, it can be liver disease. So rule in or rule out all those.
Cardiac has three parts, no? Myocardial, endocardial, pericardial. So you have ruled out myocardial cause. Can it be pericardial?
Again, there will be more symptoms of breathing
Constrictive
difficulty.
pericarditis.
More symptoms of breathing difficulty, chest pain, pericardial involvement. So it would be more of a cardiac symptoms than.
Yeah, so chest pain will be in acute pericarditis. Sir is saying this is constrictive pericarditis.
Other features of heart failure like dyspnea on exertion, orthopnea should be present.
Yeah, that's what we discussed, that usually those are present much before you get edema, or at least simultaneous with edema.
Inferior vena cava obstruction. But Chiari syndrome.
What do you think?
But Shari will come with abdominal distension first, more than lower limb.
Very good, very good. So we are talking of liver disease. Can this be liver disease?
Again, liver diseases, the child is not absolutely all right. It is unlikely for it to be liver disease because it's an acute history before that.
And again, there would be abdominal distension and yeah. Can it be malnutrition alone?
It will not present so acutely. There will be chronic edema and chronic growth failure.
So how
Growth
will
failure
that
is on
growth
history,
failure
yeah.
come? See, chronic edema means, edema of 1 month is chronic, edema of 3 days is acute. But edema of 1 month was 1 day edema of 3 days, no? So how do you separate the two?
Child will not be absolutely all right. Child will not be absolutely all right before the starting of edema.
So frequent illnesses prior to this is expected if it is just malnutrition, right?
I think there is no disease which presents with acute onset of bilateral edema. That's your first statement. Okay, what could be the cause of that? Lymphedema or a venous obstruction? There has to be a cause for that. There has to be a large tumor obstructing the inferior vena cava and producing bilateral edema. What happens to that tumor symptoms first? And then comes the edema. So that is out. Acute lymphedema, yes. For example, an infective. Okay, but that comes with fever and edema. So this is only edema. So this is neither venous obstruction nor lymphatic obstruction. That's right. But it is not a generalized edema so far. So we are discussing localized edema, and we have ruled out both causes of localized edema. So therefore, you need to look at whether this is an acute or chronic condition. Acute, yes, but underlying is a chronic condition. Okay, and that's why my first impression is this is an acute on chronic disease, which is producing for the first time a bilateral lower limb edema. Why is that? Because the child is standing and walking. It's a dependent part. But some previous illness, this child must have had. Now what previous illness? No cardiac, no symptomatology, no liver. Okay, why no liver? Because no jaundice? There may not be jaundice. Then why no liver?
Ascites should come first, more than lower limb swelling. And again, the child was all right before the onset of this episode. So,
Small
not-
amount of ascites may not produce distension. There may be fluid in the peritoneal cavity which you can't know just by history, but edema is seen. There is fluid in the peritoneal cavity. Good, 500 cc is there. But you can't see that
Is it acute liver disease or a chronic liver disease we are talking about? When we are talking about
Chronic liver
chronic.
disease.
Why not acute? Even acute.
That would be a sick child, and jaundice would be very
haven't seen much.
significant.
You just come for this. So why not acute? Even acute liver disease may come with ascites also. Certainly not commonly. But tell me strong reason why it is not acute liver disease.
No jaundice.
Correct. Acute liver disease has to have a jaundice or an acute liver cell failure, a Rice syndrome. No jaundice, no time to develop jaundice, but you have an encephalopathy, hypoglycemia, hyperammonemia. So acute is out. This is chronic. How does the chronic liver disease start? Starts with abdominal distension. Okay. So this is unlikely a chronic liver disease as of now. But we'll keep that in mind. Because abdominal distension in a small child is normal event. Okay. Why normal event in a small child? Abdominal distension is abnormal, no? And I said in a normal child.
Due to obstruction or platters.
A normal child has the liver occupying mostly in the abdomen. Okay. Often there could be hypertonia. So the abdomen looks distended a little. Okay. So we keep that in mind. What did I say? Acute on chronic. I am looking at which chronic disease could be asymptomatic. Okay. This is an asymptomatic child as far as we know. But we have already said it's a chronic problem. So now is chronic liver disease an asymptomatic child? Almost yes. What symptoms? Not doing well. But that is common to all chronic. But if you ask any fever, no, cough, no. Is he playing years? Is he eating years? In other words, we have said it again and again each class, that your story starts from making sure that you are all right. And I think that's the commonest mistake we often find. And asking them whether it was fever, cold, cough, etc., no. But asking them whether he was as playful as before, he was eating as before, was his behavior all right, all personal history. There has to be something wrong in this child. Loss of appetite, loss of weight, behavior change, activity, energy change. You will have to ask many things before you say that he was all right. Again, I know that even I was trained 6 decades ago saying apparently well. Thereafter I have realized why apparent? You have to be really well or not. And I think learn to get rid of that real apparent. That's making a mistake. Okay. So chronic liver disease, he has to be an abnormal child prior to edema. Protein malnutrition, he has to be. Okay. What about nephrotic syndrome? He is also asymptomatic. So now the question is, can nephrotic start with edema of feet? That's the question.
If the periorbital swelling is not noticed sometimes because it's usually present in the morning and disappears later, but because the edema, because the child is ambulant, there could be the pedal edema could be more noticeable. So nephrotics can present with.
You're right. But tell me, let me correctly, which nephrotic can start without the typical periorbital edema, etc. We've been saying that an acute onset edema always is periorbital. And that's renal or angioneurotic edema. Okay, you wanted to say something. So I'm asking which nephrotic may start some other way or typical way. Okay, let me ask you the other way around. Okay, which type of glomerular disease has edema which is not a prominent feature? Mild edema. Alien. Okay, mild edema. Okay, so acute onset edema is there, but this doesn't look like acute. So as I said that, can nephrotic syndrome commonly is an acute because there is an acute hyponatremia contributing to an acute edema, not the proteinuria. So this child must be having proteinuria, asymptomatic. On the top of it, he may have a nephrotic. And why? Because subsequently you say his edema is increasing everywhere, generalized edema. So question is, was he already hypoproteinemic? Okay. And what's the cause of asymptomatic hypoproteinemia? Malnutrition. So you must be a child with protein malnutrition. Come here, there is a special. So I think we will have to devise something. This is atypical. But the atypical makes us, even now, try to make out how you can debate that atypicality. So the nephrotic syndrome, which appears to have started not periorbitally but over the legs, seems to be some kind of a hypoproteinemic condition prior to it, and that in our epidemiology, 1.5-year-old is often PEM. So this child has a PEM, on the top of it, he could have developed nephrotic syndrome. Now, why should he have developed nephrotic syndrome? PM is getting worse, no?
Acutely it is progressing.
So generalized edema with ascites maybe, that's what you described, is not a feature of PM. And therefore I want to bring PM with secondary, but all asymptomatic. So my first guesswork is PM alone unlikely, nephrotic alone unlikely, PM in a nephrotic syndrome. Okay, not easy. And most of your nephrotic syndromes are happy, healthy children.
Can it be any other cause of hypoalbuminemia? Uncommon. Can it be? A hypoalbuminemia, but not presenting as PD. Because there may be no significant, as sir pointed out, it's a hyponatremia, electrolyte disturbance, which will contribute to edema and acute edema. Is there any other cause?
Protein losing.
Yeah. Is he losing protein? He's not losing in his urine. Can he be losing it elsewhere? He may be losing it in the gut, which you will not know. Are these children happy? Usually they are happy. This may not be known. So not necessarily, it's an uncommon disease. But we keep that also in mind when we have to explain uncommon symptoms, so you have to think of uncommon theologies also.
I think, can we have the mother, she's the child, right? As the child? Can we have one of you ask the history to tell me whether he was really well 3 days ago? And then maybe also quick examination, because then we can look at the examination findings. Who can just call that child?
What is the name of the baby? रूही. इधर आ जाओ.
Somebody to ask her a question to find out whether this child was really well prior to that period. That's what we want to pick up, right? Who will come forward? I thought all of you may rush. I was worried. Come on. Somebody, doesn't matter. Okay. See, at the end of near 60 years, I am making mistakes. So where is the problem if you make mistakes? Okay, that's all right.
Percentage of mistakes and percentage of getting accurate.
Speak. Give her a mic also. Yeah, she will say.
16 महीने का क्या प्रॉब्लम हुआ था उसको?
पाय सुजले.
पैर सूज रहा था. कब से चालू हुआ?
काय झालं त्याला?
पाय सुजले.
केव्हापासून? त्याच्या अगोदर अजिबात नाही. ते पाय सुजायच्या अगोदर थोडे डोळे सुजलेले वाटले तुला?
थोडे डोळे सुजत होते.
डोळे अगोदर सुजले का पाय अगोदर सुजले?
झोपत होते तेव्हा डोळे सुजले होते आणि पाय सुजले तेव्हा आला.
त्याच्या अगोदर एकदम छान होता, खेळायचा, पळायचा, धावायचा, लवकर थकायचा नाही, ताप नाही, काय नाही, खाणं पिणं व्यवस्थित, अंगावर पितो आणि बाहेरचं दूध नाही, पण जेवण 4दा जेवतो, सकाळी नाश्ता, दुपारी जेवण करतो, अंड पण खातो.
अंगावरचं पाचता का अजून? अच्छा, किती रात्रभर मागत राहतो का झोपतो आता? मग किती वेळा पाचता 24 तासात? किती 5-6 वेळेला पाचता अंगावर? रडला की घेतं? मग घेतो का? दूध येतं का? What's your comment on 1.5-year-old child being breastfed? We are told that up to 2 years you continue. Yes, you are right. What's your general impression?
Seems like child is still predominantly breastfed only as compared to
So very likely the breastfed baby at this age may not be getting enough breast milk. Okay. And when the child gets breast addicted, he is unlikely to eat well. And I think that must be the way to go by. Though she says that he is fine, etc. Yes, but there has to be some clue to say that I anticipate some issue there, right? Though she is right, कहता है तो चालतो का चाल आणि पळतो का? धावतो सुद्धा आणि बोलतो का थोडं काही? बाबा मामा दादा बोलतो? बरं. आणि हट्ट करतो का? हट्ट करतो. Every addicted child is a stubborn child because he wants the breast and the mother wants him to eat, and then he is starving, semi-starving, so he is getting irritable. Then he doesn't get what he wants, and even if he gets, he is not satisfied. So stubbornness is one cause. Then a stubborn child doesn't eat. Okay, and she is going to try more often. Then she would give him a biscuit maybe. Okay, and that takes care of his nourishment. So there is no. So I think we'll have to find out. The story told me that this child is not normal. Now she says everything is all right. So we have also to learn what is her perception of normality is not the same that we are looking for. But we will not just brush away her statement that the child is all right. I take a note of that. Let's see how we go. Now somebody else come and give her observational findings. Only on observation. Come, one of you. Come. Doesn't matter. Any one of you. Come, doesn't matter. We just talk whatever we can see. You can say that I can see a woman with the baby sitting on the chair. You start. Doesn't matter. Yes. Come.
Hold the mic close to you so that our online friends can hear. So you've seen many nephrotics. They are generally
happy.
Here doesn't seem to be happy. So you start making that observation. Is this stranger anxiety? Why not?
So you looked at the behavior, irritable on disturbance, and as soon as irritation is over, quiet. What kind of behavior is that? That's the behavior of a protein malnutrition. Okay. And is nephrotic a protein malnutrition? Well, hypoproteinemia, no? Much severe. So he must be very irritable, he must be very lethargic.
What is the difference between the hypoproteinemia of nephrotic and of malnutrition? Both are hypoproteinemic, but there is a big difference.
Sir, apathy.
Yeah, that is the clinical manifestation, but why? Why you nephrotics don't have apathy or chronic liver disease doesn't have apathy? They are also hypoproteinemic to the same extent, even more.
Genesis of hypoproteinemia.
In nephrotics, proteins are lost in the urine, whereas in malnutrition condition, they are deprived of proteins. So maybe that's why the child is irritable.
There's a little difference, something else. Anybody?
What is the cause of skin changes, hair changes, mental changes in proteinurity malnutrition? Is it hypoproteinemia? If that was so, then nephrotic liver, everybody would have had that. So those changes are not because of that. Those changes are because of amino acid deficiency. And when does an amino acid come up? So in nephrotic, you are losing not amino acids, but the whole protein itself.
And there are two types of amino acids. They are essential and non-essential. Non-essential can be synthesized in the body. Essential have to come through diet. That's why there is a deficiency of essential in malnutrition. In nephrotic and chronic liver disease, diet is okay. I mean, they are eating all types of amino acids. So that difference of deficiency of essential amino acids.
I can see the hair changes, right? Hair changes are all right.
Would you agree this is sparse hair?
Okay.
Sparsity of hair.
Little color, okay. You can see that.
Agree or don't agree?
Yes, and the hairs appear to be sparse.
But
He shaved.
yeah, so he is like.
Even he has sparse hair.
So you need to.
Lusterless.
Huh?
Luster, lack of luster.
So, okay, so do you think this is lusterless? So what exactly do we mean by sparse hair when you talk of malnutrition? Anybody? Thin hair, then hypopigmented, then easily pluckable, right? So this is like Khare sir said, it's just a cut. He's been cut, haircut is of a very small hair, but otherwise they are not sparse, right?
I think many times you might get a feel that there is some pigmentation, etc. And you must not forget to ask the mother, "ये पहले से ही है ऐसा?" And she will almost say yes. So don't forget to ask. If you are not sure, ask that question, and then you will know that this is normal really.
Also, application of oil makes the difference in the color.
What's the growth like? Growth, physical growth.
So the growth, it seems to be. So growth seems to be appropriate for age.
Appropriate for age. What do you think?
What must be his weight and height?
So
Height is difficult to guess,
Height.
but weight?
weight, he must be overweight because
No, in kilos.
in kilos around 5.5.
No, 5 is too less.
The stature seems to be small, but look at that. Stature alone doesn't say anything. Okay, one of our prime minister was very thin. Okay, he was fit. So you need to see subcutaneous fat, you must see the muscle mass. And if both are all right, then he has a genetically a short stature. What do you think about muscle mass and what do you think about subcutaneous fat?
So there is increased imposition of subcutaneous fat around the abdomen, but muscle mass also seems to be on the reduced side.
So see, on inspection we'll get confused because some areas are edematous. So lower limbs are edematous, abdomen is distended. So where will you look for all this? You look here on the arm which is without edema, right? So do they look like normal arms of a 1.5-year-old or thin?
Thin.
Why? What is the mid-arm circumference philosophy?
It is age-independent criteria.
Why is it age-independent?
Because subcutaneous fat replaced by the muscles.
So as fat goes on decreasing, muscle goes on increasing, but the total remains the same. So the point is that this doesn't look like a 1.5-year-old ka arm, right? So there is some deficiency there.
Of course, look at the mother also. Okay, genetically she's also thin, small. So we'll keep an option on. Okay, maybe he's going to be irritable. Can we put him down and quickly examine
You
his
have
abdomen?
a bed or bed sheet. उधर ले ले वो.
Oh.
Maybe they'll examine the mother's arm.
ऐसा
or-
ascites वगैरह नहीं जमणार.
एक 2 मिनिटात पोट बघून घेतो हां हां
नाव काय त्याचं? रुही. ए रुही.
that side so that they can go on that side.
Come one or two, come join because we can do it fast. You can add to the findings. Come.
Abdominal inspection. Abdominal inspection. Be quick.
Sir, on inspection, the abdomen appears to be distended, umbilicus is inverted, and there are no distended abdominal veins seen.
Okay. Are the blanks full? Yes? Blanks are not full. Blanks are not full. Umbilicus is down, not in the center. Which means something is occupying in the upper abdomen. Okay. Whatever we could see, we don't want to disturb her. Okay. I think she can go because she will get upset. Her baby is not there. Sit down, sit down. I think two things. The baby looked very irritable on disturbance. Okay. But moment the mother picks up, the baby keeps quiet. So it is not the fear of the crowd. If there was a fear of the crowd, he would cry till the child is out of the room. So this is some kind of an encephalopathy that I see. Okay, we like to check again and again. We are just looking at 2 minutes and trying to make out something. The other thing is the flanks did not look full. Okay, and therefore, and the umbilicus was not in the midline but had shifted down, which suggested that there had to be possibly an hepatomegaly. Okay. Now this is the way to look at it.
Now, since we are considering nephrotic as a possibility, and this child in the history you said fever, so what else will you think of? Nephrotic, fever, history, and now this child is irritable.
Encephalopathy due to liver disease.
What I am trying to say is there any complication of nephrotic that you should keep in mind? Peritonitis. So now how will you rule in, rule out? What else will you look for? Like sir just said that child moment is in mother's arms is quiet. So this is because of abdominal pain.
Guarding will be ruled out, peritonitis.
If there is guarding, it helps you, but there may not be guarding always, right? What else?
It will be vomiting.
Okay, so any GI complaints, vomiting, loose motions. What else?
Was he looking sick to you? He was not looking sick. Okay. So there is no acute complications.
And as sir said, look at this flank fullness very carefully. So you have a very nice round, that is not flank fullness. Flank fullness is fat at the sides and top is not so high. That is flank fullness. So for peritonitis you must have very frank fluid in the abdomen, no? So which is also here not so visible, right? So these are all the points why you would say less likely peritonitis here. But keep all this in mind and keep debating for and against, right? Okay. Yeah, give us your summary.
Gradually progressive swelling starting from bilateral lower limbs and periorbital puffiness, having diurnal variations, and later abdominal distension in a birth and developmentally normal and fully immunized child, most probably renal disorders. Probably first episode of nephrotic syndrome, second nutritional cause of edema, third is congestive cardiac failure may be there.
Go on examination.
On examination, child is apathetic, not interested in surrounding and afebrile. Vitals was heart rates around 120 per minute, which was regular, and RR was 30 per minute, which was regular, and peripheral pulses well felt, central pulses was well felt. Extremity was warm, and blood pressure was 90 by 50 millimeter mercury, which is in between 50 to 19 centile. Anthropometrically, child weight 8.5 kg, which is in between -2 standard deviation to -1 standard deviation, expected to be 10 kg, and length is 75 centimeter, which is in between -2 standard deviation to -1 standard deviation, expected to be 79.7 centimeter. Weight by length is equal to in between -1 standard deviation to median. Then mid-arm circumference, which is 13.5 centimeter, which is in between -1 standard deviation to median, expected to be 14.1 centimeter. Then head circumference 43 centimeter, which is in between -3 standard deviation to -2 standard deviation, expected to be 46.1 centimeter. Anthropometrically, it's a normal child.
So any caveat here?
Weight could be more because of the edema.
So how much could be more because of the edema? Okay, I will ask you ulta. So when somebody gets dehydrated, how much is the weight less due to dehydration?
Depending upon the amount of dehydration.
Okay, so tell me.
5 to 10%.
5 to 10% in all.
Less than 5% in mild, 5 to 10 moderate, and say more than 10%.
Is the age important here? So what you are saying is correct. That is for infants. And for older children, it is 3, 6 and 9. 3%, 6%, 9% for older children, right? So we roughly go by that formula reverse. So now this is 1.5 year old, so we'll take him closer to infant. Even if you take moderate dehydration ka opposite, moderate edema, so 10%. So 8.5 ka almost 850 grams could be just due to the edema. So his actual weight could be 7.5 kg. Very rough. So this is the way you have to think and decide, right?
Yes.
Okay.
In head-to-toe examination, anterior fontanelle is open 1 by 1 centimeters, and frontal bushing present, then pallor present, periorbital edema is present. There is no sign of vitamin deficiencies, and bilateral subcentric cervical lymphadenopathy is present. Nose piercing was there. Then otherwise, oral thrush was present. There is no cheilitis or glossitis. There is back banding in back. There is a branding was present. Then abdominal was mildly distended. Bilateral lower limb pitting edema present. Otherwise, genitalia and spine was normal.
What's your comment on that? Go back. Is that all right? I thought when I saw that open fontanelle, periorbital edema and pallor, I knew it was a hypothyroid. Delayed closure of fontanelle, periorbital edema and pallor, classical combination of hypothyroid. And hypothyroid has some edema, right? We were off the track. Your comments on that?
Come on, any thoughts on why this is not hypothyroid?
So he is ruling out.
Hypothyroid child would have been lethargic, would have been there would have been delayed development as well, and
There is a history of constipation, umbilical hernia. Hypotonia is there, hypothyroidism.
What else?
No goiter. No goiter.
And goiter is not mandatory.
Edema of hypothyroidism would not progress like that from like bilateral lower limb edema.
See, he said lethargy, hypothyroid, short hypothyroid. Everything looks like hypothyroid. What more do you want?
So do hypothyroid have pitting edema?
No.
Mixed edema.
Non-pitting. Mixed edema is there.
Okay, it's a lymph edema.
Non-pitting edema will be present.
Most important is hypothyroid at this age is congenital and he would have had a delayed milestone. Okay. Nitin, what's the cause of that large fontanelle? Hydrocephalus?
Rickets.
Vitamin D deficiency.
So you must find out first whether the inner table is already closed and an outer table will close thereafter.
Okay. Go on.
In systemic examination wise, respiratory system area entry bilaterally equal, which is clear, and CVS wise S1 and S2 present, there is no murmur. CNS wise tone, power, reflex is normal. Then per abdominal wise, on infection, abdomen is uniformly distended, umbilicus everted. There is no visible pulsations or scars or sinuses. There is on palpation, guarding present. There is no organomegaly. Abdominal girth was 42.5 centimeter. On percussion, tympanic note was there, and on auscultation, bowel sound was present.
Are you worried about no organomegaly? 1.5-year-old child, mildly malnourished, okay, pale, and no organomegaly at all, liver not palpable. What's your comment on that? I think the liver is shrunken. Every infant has a liver palpable. Okay, this is impalpable. So what's your comment on that? See, in an examination you are going to be caught like this. Okay, the case may be very simple now finally, all of you know. But when we approach, there are many small little things that examiner is looking at. So who will comment on what I've asked?
Because of the abdominal distension, probably we were not able to appreciate a liver.
Okay, one explanation. Anything else? That's what. So she said ascites and abdominal distension, you're not able to palpate the liver. Anything else? So when do you actually get a small liver?
Cirrhosis, later stages.
Last stage of cirrhosis, which is not seen in pediatrics. Because it takes years, and by then, any other situation? What happens in marasmus?
The liver fatty liver.
Marasmus fatty liver?
So impalpable liver at this age is almost rare. Theoretically, yes, possible. The first thing is you must make sure whether this liver is normal but lying in the thorax and not in the abdomen. And what's the cause? Eventration of diaphragm, not diaphragmatic paralysis, that's another cause. Okay. And therefore you need to see whether this child obviously has a normal liver, but the normal liver should be palpable. So it's likely that liver must be palpable. In fact, I thought from a distance that the liver must have been there because the umbilicus looked little down. Okay. In an exam you would say liver, one finger palpable and soft. Okay. So no discussion. All right. So sometimes you know how to bluff correctly. How can we bluff correct? Yes, this is the way to correctly bluff. Otherwise it's very, very difficult. Severe marasmus may have every organ small, including the heart. You see a microcardia, you see a micro liver, but that's very rare. Today we don't see extreme marasmus, and we don't see extreme marasmus is seen sometimes, but we don't see kwashiorkor at all. Which means the present government has enough proteins for our children. What do you think? We don't see kwashiorkor. I'm sure he has also seen. I've seen many kwashiorkor. In fact, in a well baby clinic, which is the Lions and Rotarians organized, the first prize always went to kwashiorkor because he was the maximum weight fellow, looking big. Why are we not seeing kwashiorkor today? Nutrition has improved in the country. So earlier, calories were enough, proteins were low, so we saw frank protein malnutrition. Today both are low, so if the calories are low, the growth is small. For small growth, protein is also required small. So when there is a disproportionate calorie and protein, you get marasmus or you get kwashiorkor, and today you mostly see PEM because both are down.
Anything else you notice in the findings that is a little coming in the eye?
Abdominal girl 42.5 centimeter. That AG is that, no?
Yes, 42.
So take a note. Liver must be palpable, may not be, okay.
What about guarding? So you thought there was guarding, generalized or localized?
Generalized.
Generalized. So what would it mean to you?
Maybe due to infection, peritonitis. Maybe
Correct. So now which is the other finding which is not fitting in? You said tympanic note all over.
Yeah, fluid.
So have you got signs of free fluid? No. So if you've not got signs of free fluid and you talk of overall guarding, the two things don't go hand in hand, right? So one of them is possibly not there. So now in young infants, and she's especially irritable. So whenever you try to palpate, she is resisting palpation, which you are interpreting as guarding, but it's not really guarding. Okay?
Okay, sir.
Fine, go ahead.
One and 5 year old 1 year 5-month-old female child came with complaint of gradually progressive pitting edema with abdominal distension with no prior history in an otherwise normal child. An examination suggestive of abdominal distension and periorbital edema and normal other system is probably a case of first episode of nephrotic syndrome without complications.
How will you investigate the child?
Firstly, first,
how will you investigate?
Spot urine protein will be.
Okay, speak in the mic.
Spot urine albumin will be.
Okay, why spot urine protein creatinine ratio?
Sir,
you said protein creatinine ratio. Why? You're right, but
yes,
why? Okay, anybody?
There is loss of protein through the because of the glomeruli. So there will be increased protein loss, but the creatinine is not. The creatinine excretion is not increased. So there will be increased protein creatinine ratio.
Yeah, so why not just a simple urine routine which tells you that there is 3+ or 4+ proteinuria? That's good enough to diagnose nephrotic, no?
Proteins are affected. Urine proteins are affected by diurnal variation and orthostatic proteinuria. So it is clearly urine protein create ratio will clearly tell.
So nephrotic is defined by 24-hour urine protein excretion. It is not defined by a one-time urine showing 3+ or 4+. It's not defined that way. In children, 24-hour urine collection is impossible, very difficult. So urine protein creatinine ratio is a good surrogate marker for that 24-hour protein. Therefore, you also put in as the definition urine protein creatinine ratio more than 2, right? That's why you do urine protein creatinine ratio. Then what else? What other tests will you do? Others, come on. What other investigations will you do to prove the diagnosis?
So for specific investigation, serum albumin, triglyceride, urinary protein create ratio, and
high density low.
Other test CBC for
okay.
chest X-ray or Montauk's test for ruling out TB.
Okay. So why
Because there will be hypertriglyceridemia because of the increased synthesis of lipoproteins.
Okay. Okay. Have you done any investigations in this child?
Yes, sir.
Sure.
Urine for albumin was 1+, and urine protein create ratio was 7.8. And
1 minute. So see, here itself you have the answer that urine albumin is just 1+, but protein creatinine ratio is 7.8. Okay, yeah.
Then, urine protein creatinine ratio is 7.8, which is 24 hours urinary protein in nephrotic range. Liver function test in SGOT was 59 and SGPT was 69 and serum alkaline phosphate 350. Total protein was 5.8 and albumin was 2.8, which is low. And RF renal function test blood urea was 13 and 0.7 create. CRP was 83.2. Then CBC wise count was 13,000 and 13,800, and HB was 9.2 and hematocrit was 28.6 and platelets was 6,25,000, which is neutro-predominant. And PS microcytic hypochromic anisocytosis. Urinarium was NAD and urine culture was there is no growth. Lipid profile, the total cholesterol was 340 and low density lipoprotein was 258.
Wait. Tell me some other things in this investigations which bother you.
CRP
is high. Creat is high, 0.7, normal.
The child is malnourished. He should actually be having low creatinine because of low protein mass.
Very good. So what is the formula that you use to check?
KL by C. That is also
Try roughly.
0.4 into around 80 centimeter.
79, no? Yeah, so take it as 80.
Divided by
So
0.7 is 32. 46. It
How
is
much?
less. The EGFR is 46.
EGFR is 43. So she's calculated using the formula and EGFR is coming very low. So this creat is high for this child. Okay?
Yes.
So that's something which we all have to learn. We don't go by the normal range printed.
Yes.
Right?
Yes.
What else? Comment on something in the CBC which is bothering me. What is the hemoglobin?
9.2. 9.2.
So what's that 13.8?
13.8 is TLC, total leukocyte count.
Okay. Then it's okay. I thought the 13.8 was hemoglobin. So then I said, how come you have micro hypo aniso and 13.8? Okay, fine. Okay, go on.
The albumin was 2.8, total was 5.8, so globulin was 3. So there is a reversal of albumin and globulin ratio. I learned that was a liver disease. Albumin should be more than globulin, and in this child albumin is smaller, so reversal of ratio. That is a liver disease.
But there will be production of increased production of globulins in compensatory increased production of globulins in nephrotic.
So ratio is important, but absolute values are also important. Here the ratio is reversed not because of rise of globulin, but because of fall of albumin. So that's we'll interpret it that.
So how will you treat this child?
It is the first episode of nephrotic syndrome, so I will give prednisolone 2 mkd per kg powder per day for 6 weeks. Thereafter, next 4 weeks, 1.5 mkd.
He has fever for a day. Are you worried?
Sorry?
He has fever for a day and you felt that the abdomen was little distended. In fact, you felt it was guarding also. Are you comfortable or you want to rule out?
Rule out, sir. I want to rule out COX.
So how will you rule out COX?
The count is normal.
How will you rule out COX in this baby? How will you rule out tuberculosis?
And maybe peritonitis, spontaneous peritonitis. You said guarding, fever.
Yes, sir. But ascitic tapping.
Have you done?
No, sir. Ascitic tapping can be done.
Yeah.
No, yes, sir.
So that is to rule out tuberculosis or?
No, sir. Peritonitis.
Peritonitis. How will you look for tuberculosis in this child? Chest X-ray. And if that is normal?
Montu test and sputum for gene.
Sputum, how will you get in this child?
Gastric lavage.
Gastric lavage.
Do you want to do sputum in every child of nephrotic whom you want to treat? Do you do that for every child? Would you like to have few things also added to history? How will this child get tuberculosis? From where?
Contact.
हवा से उठते आएगा? Contact. So did you ask for a history of contact? Okay. Mother had tuberculosis 8 years back. Important? Maybe, unless she has an active TB now, that child. So history of contact, little more details, then you think of tuberculosis. Otherwise, doing X-rays is just understandable. Mantoux interpretation is difficult. You may do, some people will insist on doing that, is a different story. But otherwise, are you going to do BAL or bronchoscopic aspiration? Probably not.
So, usually we said nephrotics are healthy absolutely prior. So there your X-ray chest is a reasonable screening investigation. This child being malnourished, you may go one step further and look for GL, for AFB, etc., right? Before you decide.
I think the Mantoux test is not for diagnosis, it's a good test for infection. And if I can prove that there is no infection at all, then that might be a good idea. But of course, Mantoux could be negative because of the nutritional ratio. But suppose the Mantoux is positive, then I start wondering more so, and then look possibly if something more. So if I get a Mantoux negative, no infection is no disease. Of course, there is always a caveat for all that. But there are a few things that are still worrying us. One is that this child has symptoms clinically what look like a protein deficiency. He is lethargic, irritable on disturbance. Okay, that's not a nephrotic syndrome. Second is, 1.5 years is a bit early as compared to classical 2 to 5, but that doesn't worry us greatly. It's not the only reason. But the third is, creatinine is high. Okay, why is creatinine is high? Okay, that means there is some endothelial component. Okay, nephrotic is an epithelial glomerular disease and creatinine is an endothelial problem. So is it, but do you think he could be dehydrated? So because he is edematous, okay, he has a tachycardia, okay, he could be dehydrated. And if he is dehydrated, then creatinine may be high, right? Yes?
Come on, 2-3 questions. Normally nephrotic is dehydrated or well hydrated? Take the mic.
Dehydrated.
So can you qualify that statement? Dehydrated as in which compartment is dehydrated?
Extravascular.
So intravascular, there may be normovolemia or hypovolemia. Little bit of hypovolemia, right? There are two theories, as we know, of the genesis of edema in nephrotic syndrome, right? But will that lead to raised creat is the next question sir is asking, even if it's hypovolemic.
Sir, increased breakdown of proteins and their subsequent loss would lead to increased creatinine.
So increased creatinine is basically a reduced function of the glomerulus, right? And dehydration would lead to an increase in urea. So you would have your blood urea raised but not creatinine because of dehydration, right?
But don't forget that pre-renal condition can also get into renal failure. So whenever a creatinine is a little high, one could also look at the urea as well. Because we are not happy with that creatinine. Okay, by all formulas we said that that is abnormal, and we have many other abnormalities in this child. Okay, lastly, most of the nephrologists now tell us that nephrotic syndrome and nephritis are similar conditions. After all, nephrotic is also inflammation of the glomerulus. But in our mind, nephritis is inflammation, but nephritis is an inflammation of endothelium. And a nephrotic syndrome is an inflammation of an epithelium. So both are glomerulonephritis. And the manifestation could really be overlapping to an extent that a classical endothelial disease may have a little more edema, and a nephrotic may have a little hematuria or whatever. And I think there are too many abnormalities in this child that we need to really look at on a follow-up as well as in. But the best way is I'll do a renal biopsy, no? Yeah, because it's some funny kind of nephritis, not just nephrotic, okay, not classical nephrotic, minimal lesion. So why not do a renal biopsy, early diagnosis of any unusual condition? What's your point against it?
Acute history, there will probably not be enough changes histopathologically for it, and they did not meet the criteria for biopsy.
Hypertension, hematuria. In this child, no hypertension, hematuria, or other findings suggestive of chronic or glomerular injury.
We have not tried a course of steroid also. I mean, after that, if it's not responsive, then we can.
You are right that the indication of renal biopsy would be largely a failure of steroid therapy. Okay. Okay. So one would not rush into that, but there are few unusual situations here, and I think that makes me feel that we must look at something little more. If the creatinine is already high, then is there a glomerular failure already occurring? Creatinine abnormal is a late sign of a renal failure, not early, and it's already occurred. Why should that occur in a first episode of nephrotic syndrome? So if this child has something amiss that clinically is not possible, we'll keep that in mind.
We were also a little bit concerned about his nutrition, weight, etc. One of the ways to go about is, of course, a little more detailed dietetic history. Okay, about it. Is there any other things which you will look for or ask from the parents which will guide you how this nutritional status child has evolved over a period of time, which we often don't do? Growth chart. So you may not have the growth chart kept, but at least 2-3 weights taken. This child must have gone for vaccination in municipality. They will almost never put a point on growth chart, but if you have one, this growth chart will tell you how this child has been in infancy. Relatively good period in infancy, 6-7 months, then a flattish curve thereafter, and even flat or even losing down is a real story of a malnutrition in largely breastfed baby where the mother doesn't have much breastfeeding, and semi-solids have not yet picked up as well as they ought to have. So don't forget the growth chart in a difficult situation, making difficult situation very easy to interpretation, because every disease the growth chart is different. And therefore, if possible, get 2-3 weights and put it on the chart so that may sort out the problem of nutrition in this child. You said prednisolone. You want to give it in divided doses or single dose? You want to give it on the weight basis or surface area basis? You want to give it as a single dose or divided doses? Single dose in the morning, in the evening? Morning? Why morning? In the morning the steroids are so high, normally also. And evening they go down and you want to give it in the morning. The high becomes higher and when it is not there you don't supplement. It's funny. You want the steroids to be there all the time, no?
What is the logic of morning?
Logic of giving in the morning is to mimic the normal circadian rhythm.
Yeah, but in the evening no steroids in the body in spite of being such a big dose. So in the morning the albuminuria will disappear and in the evening albuminuria will appear. Don't you need to maintain a constant level? So the half-life shows that in the evening it is less than what it is required. The answer is you don't have to have constant drug levels all the time for 24 hours. You should have a good level which will control the inflammatory process. You don't have to keep it all the time. And in order to prevent, what do you want to prevent? Pardon me? You want to prevent when you are giving steroids, ultimately there is going to be depression in ACTH activity. So that should be minimum. So in the morning there are steroids in the body, but what stimulates ACTH? The low level of steroid. So if you give steroids in the evening also, that means morning also the steroids are high and evening also the steroids are high. So ACTH suppression is even more. But here you give morning and in morning they are high, fine, that covers the inflammation very well. But in the evening steroids levels are low, so ACTH stimulation goes on. And therefore following stoppage of steroids, the ACTH going down. So almost always nowadays we prefer a single dose of steroids in the morning because the steroids are normally, you want them to be low in the evening in order to keep the incidence. Okay, even for asthma these days, a single dose in the morning after breakfast is what is recommended rather than just for 3 to 5 days. Okay, and then you will take care of acidity, etc.
And I think the important point is a steroid will suppress adrenals. Even in a small dose, steroids suppress adrenals. And therefore, we want a maximum dose that is therapeutic. We don't want an additional steroid coming from. Why do we go external steroids? We have an internal steroids, no? But we want a dose that is required to suppress this inflammation. Therefore, we are giving 2 milligram per kilogram, whatever. And that in turn would suppress the adrenals, whatever little the adrenals produce will. In fact, a 5 milligram of prednisolone to an adult also will suppress adrenal for a while, but it will not suppress the rest of the adrenal function. So morning dose is largely given for a safety, okay, to minimize toxicity. And that's why single morning dose, subsequently alternate dose to further minimize toxicity. And why? Because we are giving a very high dose which is likely to be toxic, and we don't want an additional steroid from the adrenals to come up. So we want an adrenals to be suppressed. And that's the reason why by the time you are giving it for 3-4 weeks, you are likely to be immunosuppressed. And you might have a problem also of infection by then. But we don't mind that. We will face it. And then, of course, we will keep a watch on hypertension, we keep a watch on posterior subcapsular cataract, all that. But that is why safety demands that we give a single dose in the morning. Right?
Fine. Any questions on this? Yeah.
In this child with fever and high CRP, are we safe to start steroids for investigating further?
So that's what we said. We are not happy to call it a proper minimal change nephrotic right away. So I wouldn't be in a hurry to start steroid. One, I would look at the infection component properly, and I would evaluate further whether this is a chronic kidney disease or something like that before deciding on steroid. So steroid can wait in this child. Any other question? Okay, so we start with the second case for today. Who's presenting? Come.
You have no comment from the...
So from our online people, both faculty are there, Dr. Palni Raman and Dr. Mahesh Moite. So they have made a lot of comments, but they are exactly same as what we have been discussing here. Palni Raman just made one additional point that pulse pressure in this child was also normal and hematocrit was below normal, so no dehydration, so no reason why creat should be high. Means same point he was making, right? Yeah.
Start.
You may repeat creat once when we do next investigations.
Huani Enon.
Good evening, everyone. Today I am presenting a case of 2-year-old female child who is born out of third-degree consanguineous marriage, second by birth order, Hindu by religion, hailing from Dahisar, brought by mother with complaints of not gaining weight and height since 1 year of age, not able to stand, noticed by mother at 1 year of age, and cough and cold since 4 days, increased work of breathing since 1 day. Child developed cough cold since 1 day, which was dry type, non-spasmodic, not in bouts, associated with increased work of breathing in the form of fast breathing, noticed by mother since 1 day, which was not relieved by oral medications. There is no history of fever, no history of ear discharge, no history suggestive of any foreign body ingestion or choking. Mother mentioned that child is not gaining height and weight since 1 year, and the child is not apparently all right. Child is having history of fever on and off almost once monthly since the age of 3 months, which were relieved on medications. There is no history of loose stools, no history of bottle feeding, no history of polyuria, no history of any recurrent cough cold, no history of COX or COX contact. Mother noticed that child was not being able to stand at the age of 1 year, which she identified as abnormal comparing the milestones achieved by her elder sibling. So the developmental history becomes significant, so I would like to explain the developmental history. The gross motor wise child has achieved head control at 7 months of age, rolling over by 1.5 years, sitting with support at 2 years of age, but the child is able to sit without support when she is made to sit. She is not able to sit when she is in supine position, and she can't sit upright by herself. Developmental quotient for gross motor is 25%. Fine motor, she has developed mature pincer grasp, able to eat on her own with hand, can draw a straight line, which is appropriate for age. In language milestone, she can talk in phrases with meaning. It is 83%. Socially, she can play with peers and has domestic mimicry. Impression is isolated gross motor delay present. The child has a significant past history of multiple OPD visits for not being able to stand, which was evaluated and received medication in the form of powder, told to be given weekly once, which she gave for more than 6 months, and had one hospital admission last month for not gaining weight and height. From there, she was referred to higher center, Sion Hospital, for further management. Antenatal history is uneventful. Birth history-wise, full-term vaginal delivery, cried immediately after birth, no NICU stay. Birth weight was 3.5 kg. She is immunized till date. Family history is not significant. She has one elder sibling. She is normal. No significant complaints. Diet-wise, significant calorie deficit of 400 kilocalories with no protein deficiency. Examination.
We'll discuss the history. Yeah. So what are your thoughts on these chief complaints? Or if you want to put the whole history together, even then you can tell us what are your thoughts.
Isolated gross motor delay with child is having isolated gross motor delay with recurrent fever and recurrent illness, with not able to stand, so maybe some weakness in the truncal muscle or limb muscles.
Yeah. So as a concept, when you have isolated gross motor delay, where is the problem? Central or peripheral?
Peripheral.
Peripheral.
So as a concept, it should always be peripheral. So that means central nervous system problems are less likely. right? Now, what about the recurrent fever and all that? So, what's your thought process on that?
Respiratory muscle weakness leading to improper lung toileting, leading to infections.
Okay. So, would you want to go into more detail of all that? So, those recurrent fevers, were they big illnesses or small illnesses? Right? Whether they necessitated admission, intravenous antibiotics or what. So you need to judge the gravity of those illnesses, right? Then, yeah. And what about the present illness? Cough, cold since 4 days and increased work of breathing since 1 day.
LRTI.
So LRTI or hyperreactive airway?
No fever.
So no fever, so more likely to be reactive airway disease.
I think generally we get two different types of problems. One, either the mother says weight is not picking up or the length is not picking up. Here is both weight and height. Now a 2-year-old not gaining height for last 1 year. Okay, what is the amount of gain in height between 1 and 2? For the mother to say that up to 1 year she was all right. Okay.
16 centimeter. 15 to 16 centimeter.
So 12 centimeters in the second year. Okay. Which means if we believe the mother that the baby was all right till 1 year, then at 1 year she was 75. And then she stopped gaining height. She would not stop all of a sudden. So I'm not sure what the mother means by that. If you look at a malnutrition, the parents come saying that weight is low. They are not bothered about length. And if you look at the problem of a short stature, the parents don't talk about the weight. They say the height is not increasing.
Here, both the things are right.
So I start wondering, if I see a malnourished child, weight and height both may be low, but weight much lower than height, and the mothers never complain of length. So why is this mother complaining of height? So I feel that short stature is the problem of this child. Is my impression. Okay, if the story is right, I must start asking. You get a point what I mean. A 2-year-old malnourished, parents will never talk about the length and height. They will talk about only the weight. And many short stature children are normal in weight or even increase in weight. So what is this funny thing? So that is number one. And it started at 1 year of age. Okay. But even the head holding was late. So it's not a motor system which is only the bones or joints, no. Even the head circumference is low, right? Just shows that those milestones.
Fine. Head control you said was?
7 months.
And the roll over is 1.5 years. So does the small height do that? And does the small weight does that? Then there is something amiss, right?
So when the height is affected, you may not only think of the muscles, etc., think of skeletal problem as well. Because skeletal problem can give rise to significant affection of height, maybe little later noticed, and that will strike her. And if skeletal problem is also associated with motor development, then motor milestones will be delayed, but other milestones are normal. Can you think of some skeletal disease which can occur in this child, especially a 3rd degree consanguineous child? Affecting the skeleton, also the muscle tone, because head circumference, the head control came at 7 months, and all other milestones, gross motor do suggest either decrease in power or decrease in tone, and also short stature. Can you think of a bone disease? Can it be rickets? Maybe refractory rickets, because this particular child has 3rd degree consanguinity, but always think of deficiency first. So one thing that would occur to my mind is it something skeletal disorder associated with motor disorder as well? The cognitive development is normal, only the motor development is affected, and also short stature, as said, noticed by the parents, so significantly short. Maybe in the first year of life also that she was short, but it was not so apparent. As the child at 2 years, it became more apparent because she had something to compare with as a child. So one of the things that we may keep in mind is it a skeletal dysplasia? It need not be rickets, it can be other types of skeletal dysplasia as well, but that also will keep in. And 3rd degree consanguinity tells you that it is less likely to be deficiency and more likely to be something more.
But for rickets, what doesn't fit in those gross motor milestones? Delayed head holding doesn't fit in. What else? Why should rollover be delayed in rickets, right? So rickets typically, when there is a motor delay, the initial milestones are actually normal and then the motor delay sets in. That is a more typical story of rickets, right?
And I think whenever the story runs for a longer time, don't forget to ask what is happening to the health status of this child. Is he a sick child or he is a deteriorating sick child? Because as Dr. Khare said, renal rickets, okay, but the renal rickets very early should have presented with failure to thrive, okay, maybe acidosis, whatever. That has not happened. Now, if this child has complaints in 1 year, but the story runs even at 6 months and 7 months. So we need to ask the mother further, how was the child in the first 6 months? Okay. So I think we need to look little more carefully. We have an issue, but whatever it is, let's look at that. Okay.
And there is no deformity. In a child with skeletal dysplasia, the mother would complain of deformity. Here the mother has not complained of any deformity, so that's one thing to be borne in mind. There is no deformity, sir.
When we discuss all that, the parents must be out of the room, because sometimes we may convey something. Yeah? So that's why I asked her whether she follows English, but otherwise that's not a good idea. From next time, let them wait outside. We might make some funny statements which are not right for them.
Chalo, 2 people for moral support of each other and observation. Come fast.
Ask the history from the beginning also. Let's see whether the story comes from that.
Come, all of you come, all 3 come, no problem. Come.
मराठी कळते का? नाव काय बाळाचं? वैष्णवी. किती वर्षाची आहे? 2 वर्षाची आहे. तिला काय त्रास झाला की तुम्ही इकडे हॉस्पिटलला घेऊन आलेले?
त्यामुळे आम्ही आलो होतो.
पण तुम्हाला काय त्रास वाटत होतं? कॅल्शियम कमी तर दुसरं, तुम्हाला काय वाटत होतं की काय त्रास आहे बाळाला?
मग तिला ती सर्दी खोकला झाला ना, म्हणून मी इथं आलो होतो.
आणि दुसरं काय वाटत होतं बाळाला? अजून काय त्रास आहे?
नाही म्हणजे आम्हाला ना दुसरं डॉक्टरने एकदा पाठवलं होतं. ते म्हणले कॅल्शियम कमी की चालणार नाही कवाच, म्हणून आम्ही म्हणलं साईन दवाखान्यामध्ये बघू आपण जाऊन काय होतंय. त्याच्यामुळे आम्ही इथं आलो.
आणि तिला म्हणजे अगोदरपासूनच सर्दी खोकला परत व्हायचं का?
नाही हे पहिल्यांदा तिला सर्दी खोकला.
मग तुम्ही कधी बघितलं की बाळात काही त्रास व्हायला चालू झाला? आता तर 2 वर्षाची आहे ना, म्हणजे किती वर्षाची होती तेव्हापासून तुम्हाला लागलं की काहीतरी त्रास झाला?
ते 9 वर्षाची होत आली ना, दुसऱ्याची लेखा माझी पोरगी उशिरा चढली मोठी, म्हणून मला पण वाटलं ही उशिरा चलन, म्हणून आम्ही दाखवायला म्हणजे 2-3 जागेवर दाखवलं तर ते म्हणले कॅल्शियम कमी आहे, मग ती काय अपेक्षा नाही चालायची, म्हणून आम्ही गावानं आमच्या वडिलांनी मला इथं आणलं. त्याच्यामुळं तिला पहिला गौर झाला, 6 महिने अगोदर तिच्या गौर होता, 3 महिने, मग तिला ताप मोडली तिची, त्याच्यामुळे ते डॉक्टर आम्हाला असे बोलत होते, म्हणून आम्ही इथं आलो.
Got anything different?
तुम्हाला हे बाळ छोटं आहे असं नाही वाटलं? उंच होत नाहीये, लांब होत नाही असं वाटलं का? नाही वाटलं? नाही वाटलं का? मोठी मुलगी तशीच आहे, पण असं नाही वाटलं हा मुलगा वाढत नाही असं? मुलगी वाढत नाही असं नाही वाटलं?
नाही, ते दुसरे डॉक्टर आम्हाला म्हणले ती वाढन, त्याच्यामुळं म्हणून आम्ही एवढं लक्षच नाही दिलं. गावी होतो आम्ही, आई वडिलांनी इथं आणलं आम्हाला.
आपको सबसे पहले कब लगा कि बच्चे को कुछ तकलीफ है? आपने कब ध्यान दिया कि मेरा बच्चा थोड़ा अलग है मेरी बड़ी बच्ची से?
जब मैं मतलब 6-9 महीने की थी ना, तभी मुझे लगा, तो मेरे मम्मी पापा को बोली मैं, तो बोले नहीं देर से चलेंगी बच्ची, इसलिए हम लोग ने ध्यान नहीं दिया.
तो मतलब आप वो बच्चा क्या ध्यान दिया आपने 9 महीने में?
उसको पूड़ी आया था, मतलब गौर आया था, तब हम लोग को मालूम पड़ा.
क्या मालूम पड़ा तभी?
तिला ताप आहे ना, तेव्हा मला माहीत पडलं मग ही चलत नाही म्हणून.
तेव्हा तुम्ही बघितलं. तर त्याच्या अगोदर तिला ताप काय सर्दी खोकला नाही झाला, तर तुम्हाला वाटलं की ती उशिराने म्हणजे करणार, म्हणजे ती पलटी पण मारत नव्हती ना? पण ती 9 महिन्याची झाली तरीही पलटी मारत नव्हती, तर तुम्हाला काय असं वाटलं नाही की वेगळं आहे म्हणून?
आमच्या घरच्या लोकांनी डायरेक्ट तिला उठून बसली.
तेव्हा तुम्हाला वाटलं नाही की काही? Ma'am, sir, as per what she's saying, it is when she had that first measles is when she has noticed that the child is also having something else. So before that, she has left it to that the child will pick up the milestone. And as per what she is saying, it also seems that the main concern is the child is not standing. So it took her a year to get to the point to know that the child is not attaining that major milestone. So to roll over and all, she has let go. So it is that time of the first illness where she has.
So now you are seeing some signs of rickets. Okay, looking at those signs, tell me when did this ricket start? You get the question? There are some signs of rickets you see from a distance. Looking at the entire skeleton, you have to guess when did this ricket start. Okay, then we will know the origin of rickets, and that's very important. Okay.
3 months, 6 months, 9 months, 1 year.
Around 5 to 6 months, the child has got wrist widening, and that's the time when they sit in that tripod position.
Started sitting
late. So
take a note of that. Okay. What about the head?
frontal bossing.
Signs here, and okay, maybe look at the chest also. But look at the head. Okay. Would you look at the head? Would you look at the head from a distance and say this is rickets? Look at the head only. So does the head look bossing is
Frontal
there,
bossing.
right? No, but look at the fontanelles.
Open. Fontanelles open.
So the point is why the head is not taking the brunt of finding, but even the legs are taking the brunt of finding. You get the see? Normally the head attracts you about vitamin D deficiency rickets. This head doesn't.
And when she is not walking.
Yeah.
Leg is taking the brunt when she is not walking.
And that means when the head growth was maximum, the disease was not as prominent. So the head sarcophagus is growing maximally in first 3 months, then said, but at first year of life, maximum 6 months. So the disease was not so prominent in 6 months, and deficiency should be prominent when growth is maximum and chances of getting nutrition are minimum, which is first 6 months. There is nothing which is giving vitamin D, and the growth is maximum. That means the disease has started slowly, progressively over a period of time. So it's a chronic and what is known as cumulative effect.
So now start debating the etiology of this rickets. Okay. Growth is not as good. The story starts a little later and slowly worsening. What must be the etiology?
And the child is tachypnic even.
Yeah, it's very tachypnic. So obviously, by history we knew that it was rickets and it was the renal rickets only. Okay.
And tachypnic without distress. Tachypnic without much distress. For this degree, respiratory rate must be close to 60. But nasal bearing minimum.
Could it be a hypophosphatemic rickets which starts a little later in the second year, comes with problems in the legs more than anything? Hypophosphatemic rickets. Why rush into renal tubular disorder? What's your comment on that?
Inheritance.
Family. There's no family history.
Okay, so one is it's hereditary, but what else? Suppose we don't know whether it's there in the family or no, still there's something against.
X-linked.
So X-linked, so yeah, it's more common in females. The speed of progression, this seems too fast.
Yeah, usually they are presented at later age, and then you see the mother and the child, and then you take an X-ray of the spine, and you have typical presentation of hypophysis. I think the flattish vertebrae or something like that.
This child is markedly tachypnic. But I have to say that this is certainly a renal tubular problem.
Only one thing I said, just look at the tachypnea carefully and tell me what is your observation.
Jara work kara.
Retractions are present, what else? Beading is there, okay. You can see the costochondral beading. What else? Means what I'm trying to ask you is this looking like acidotic breathing?
Is it deep and rapid?
It's not deep and rapid, right?
It's only
it's rapid, but it's not deep.
and rapid.
So there could be a present pathology which is contributing to that tachypnea, right? Yeah. Fine. Now you tell us your findings.
And so, would acidotic breathing cause like retraction, significant retraction?
No, it wouldn't.
She is
It wouldn't, so that's the point. So acidotic breathing wouldn't cause retractions. However, see, retractions are something which are a little tricky to judge in such children who have chest deformities, and anyway they have a little, the ribs are pulled in and pulled out and all. So it is difficult to judge. But the point is, this is very rapid. So that's why this is not primarily acidotic breathing. Whether she has a dual component and all that, that we'll have to see.
तुम्हाला श्वास फास्ट जोरात चालतोय असं वाटतं का? हे केव्हापासून आत्ताच आहे का?
Why is the tachypnic child sleeping well?
He's adjusted.
I think what you said is right. But when the tachypnea is so much high, with probably breathing at 60 or 80 times a minute, there is no chance for a death to come. Okay. So we have a combination of all that. A child who is acidotic may usually have some problems in terms of behavior, etc. He looks to be a happy child. Of course, this means that he has a chronic acidosis. We are looking at an acute acidosis with diabetes, etc.
Adjusted.
Chronic metabolic acidosis, so slowly worsening renal tubular disorder.
Dr. Mohite has added a few things. So when Khare sir brought off skeletal dysplasia, he said skeletal dysplasia is disproportionate, short stature, and usually weight is not affected, as you also said. So that is one point that he has added. Rest, I think he has exactly said what we have been saying here.
So child was examined in sitting position, vitals being temperature 37.4 degrees Celsius and heart rate of 124, respiratory rate of 54 per minute, and blood pressure was 82/54, which is 5 to 50th centile, and saturation was 95% on room air, but on arrival she had 90 around, sir. Today she is 95. Anthropometry, weight is 6.65 kg, which is less than -3 standard deviation. Height is 67 centimeter, is also less than -3 standard deviation and less than MPH. Upper segment is 34 centimeter with lower segment 33 centimeter. Upper segment lower segment ratio being 1.03:1. Mid upper arm circumference 11 centimeter, which is less than -3 standard deviation. Head circumference is 44.5, which is -2 to -3 standard deviation. Weight for height is -3 to -2 standard deviation. Impression being severe acute malnutrition.
Are you happy with the upper segment, lower segment?
No.
What does it mean?
It is showing upper segment is.
So this is short trunk dwarfism or short limb dwarfism?
Short limb.
Short trunk. Normally upper segment is
short trunk.
That's is little unusual for a child with rickets. Short trunk means spinal are more affected, vertebrae are more affected. You will have to take the length once again.
We took, sir, 2 times, so it is same.
Weight for height may not be all that bad. Okay, 6.5 and 6.65 and 67 is reasonably.
67 is the height of a 6-month-old child, and 6.6 is also a weight of a 6-month-old child. Though we need to look into the birth weight and what is the gain in weight.
3.5 kg.
3.5 becoming 6 is hardly any gain. Doubled at 2 years.
5, doubled. Frontal bossing is not obvious. Posterior fontanelle closed, anterior fontanelle 0.5 to 5.5 centimeter, inner table being closed. On examination, from
One
head
small
to toe.
question. How do you measure anterior fontanelle?
Diagonally will measure, sir. The diamond shape.
Diagonal is like this. So from one corner to another corner?
From midpoint of the one bone to this bone.
From the straight line, as if you are drawn a perpendicular to that. So perpendicular, perpendicular, and not from corner to corner.
No, perpendicular to perpendicular. From head to toe, in chest, child has rachitic rosary, which is more felt and also seen in costochondral junction. In hands, she had widening of metaphysis, widening of the wrist joint, and she had a double malleolus on the lower limb and bending of the lower limbs and also upper limb bones. Child was not able to stand, and the child had hypotonia, so valgus and varus deformity could not be made out because there is no valgus or varus deformity. Spine is normal and genitalia are normal. On systemic examination, respiratory system, air entry bilateral equal, bilateral crepitations present, and per abdomen soft, liver 3 centimeter palpable soft, and spleen 1 centimeter palpable, liver span being 5 centimeter. Cardiovascular examination, first and second heart sounds are heard, no murmur. Central nervous system, hypotonia of lower limbs present with diminished deep tendon reflexes.
DTR is diminished but present.
Present. 2+. Sir.
What's your comment on liver span 5 centimeters and spleen also palpable?
The visceroptosis.
But liver is
because
3 centimeter and span is 5 centimeter.
2 centimeter above it is palpable. The liver is being pushed down because of visceroptosis, and also child has abdominal distension, which I didn't mention. Abdominal
Also there may be little diaphragmatic hypotonia which may be responsible for descent. The spleen is also palpable in this child. Oh God.
So on investigation, chest X-ray of lower limbs suggestive of osteopenia with multiple fractures, and metaphysis showing cupping, fraying and splaying, and also seen in upper limbs. And blood investigations suggestive of serum calcium, which was 9.3, on admission is 9.9, phosphorus 2.02, then ionic calcium of 0.7, then now it is 0.9, alkaline phosphatase is 2700, and now it is recorded high. VBG, pH of 7.34 with PCO2 of 37 and bicarb of 20.4, sodium 143 and potassium 3.4, blood urea nitrogen was 8 and creat was 0.4, which is now 8 and 0.3. 25 hydroxy vitamin D was done, which is 34, and parathyroid hormone was 361. As a part of workup, we did USG KUB, which revealed no abnormality. 2D echo was suggestive of severe pulmonary arterial hypertension with mild TR, with right ventricle systolic pressure being 70. Impression being 2-year, 2-month-old female child who is birth-wise normal with isolated gross motor delay, immunized till date, presented with signs of rickets. Maybe a case of refractory rickets because she has received treatment for more than 6 months in a therapeutic dose, which has not responded to therapy. Now we have started on activated vitamin D3, which is responding in the form of the child is regaining, child is gaining milestones. In the last 15 days, she started rolling over, and sitting. So it is responding to activated vitamin D3 rather than vitamin D2.
How will you explain the calcium phosphorus?
Calcium
is normal.
Calcium is normal. PTH is high, sir, so which is making parathyroid hormone is high, which is making serum calcium normalized.
Then why is phosphorus low?
Phosphorus is low because of vitamin D deficiency.
No.
And also
Hyperparathyroidism.
And also PTH.
That produces phosphaturia. So it's not renal tubular acidosis, bicarb is normal. Why did you not do the metabolites of vitamin D? You have done just 25 OH, which is normal or
which is normal, 34.
So you didn't do 125 and then the renal metabolites, because we will have to see whether this is hepatic or the renal conversion is affected or the hepatic conversion there.
125 is not done, sir, actually.
We need to do, because 25 OHC will be normal. 125 may be abnormal, or in 125 also may be normal, and then the further metabolite may be normal. So we need to point out exactly where the problem lies.
Yes, sir.
Sir, since the 25 is normal and on giving activated, on giving 125 she is responding, so it suggests that there is a problem at the kidney level and 125 is not getting formed. Right.
Is it osteogenesis imperfecta before you had the biochemistry?
Blue sclera, and then brittle bones will be there, but metaphysis maybe not. The X-ray findings will not be the same.
Metaphyseal changes don't occur in OI, which are there in this. And why the upper segment, lower segment disturbed? They are equal.
They are equal.
Difficult to explain.
Maybe because of fractures, lower segment.
Yeah, lower segment would have been anyway smaller than upper, and further deformities would have produced even more
shortening of the lower segment.
Because spine is not affected, but yet the lower segment and upper segment are equal. I request you to check once again.
Yes.
So Mahesh is kept asking, how do you explain gross motor 25% with fine motor normal, DQ? To which I think our answer is that there is something missing in the history which we need to get into further. So it is very unlikely that this child had a head holding at 7 months and all that. It is unlikely. So
I repeatedly asked her if she was able to control head. She was telling it was falling till 7 months. 7 months she started holding head.
no, I understand. You got that history, but I think maybe there is her understanding is wrong, or like she told her that till 9 months she didn't notice anything, and after the measles she noticed everything. So there is some shortfall in the history, but doesn't fit into any situation where your gross motor can be so poor with all other domains normal. Doesn't fit into any situation.
And so she was giving a history of the elder sibling also who walked late. So maybe then she would not have paid that much attention to every milestone. It could be possible. She said ki the elder sibling also walked a little late, so she waited a while too.
Yeah. No, she said that the elder sibling also walked late, she said. So she has probably not given much attention to the earlier milestones. So her history of timing is probably wrong. Okay, fine. Any other questions or any other doubts?
Bicarb of 20.4, there is so much tachypnea and acidosis.
No, so it's not acidotic, no? The pH also was 7.3.
So this
and
tachypnea is respiratory.
probably some respiratory illness.
Is the chest clear?
Crepitations are present.
Yeah, and also the chest deformity is adding to the respiratory problem in this particular. The excursion, the deformities, they are adding to that.
Recent chest X-ray had patches also, sir, which I have not put actually.
Which chest X-ray?
The on admission chest. This is 13th September.
Oh, yes.
You have that X-ray?
Yes.
And so you didn't get any clinical signs for the PAH, pulmonary artery hypertension?
No, sir. Which was actually incidentally found out when we just did a screening through DICO. That time we got to know that she has PAH.
There is no neonatal event as well?
No, sir.
So everyone is convinced how we discussed that this is not nutritional. That is important, means your initial clinical analysis. After that, there are 3-4 differentials. You may or may not be able to decide that clinically. But in exam, if you get this case, you have to be confidently saying this is non-nutritional based on what we discussed. That is important, right?
Sir.
Initially coming to the diagnosis of skeletal disorder is first successful step. Then it is not difficult to find out what skeletal.
I think if I understood her right, she said that
the doctor told her कि इसका height और weight दोनों नहीं बढ़ रहा है. So what sir pointed out in the beginning, that parents noticing that height or weight दोनों नहीं बढ़ रहा है is rare. So here the doctor told her when she went to the doctor and then referred to Sion Hospital.
And please also note that this is third degree consanguinity. So it's likely to be autosomal recessive disorder.
Yes. Thank you, sir.
Yeah, Dr. Narendra Singh, rickets is associated with hypotonia and hence there will be gross motor delay. So that is right, we discussed that, but it will show in later milestones, not in head holding and prone to supine, and not so much delay, as in prone to supine at 1.5 years is too late. So that cannot be explained just on hypotonia due to rickets. Fine, so I think we'll stop here. So thank you everyone. Thank you online faculty and online students who are watching us. And we once again meet next Thursday at 6 p.m. Thank you.
And I think next time these people are presenting one case, so you have a one case. Right? But good, I think today was a very good, both of you did well.
Thank you, sir.